way, which in some cases is really extremely effective. And this is an example where the importance of therapy-relevant tumor cell properties is important, because the cells need to express the relevant markers which the therapy relies on. In the common immune therapy, there is the question whether the cell, the T cells, are silenced or inactivated by the tumor cells. The tumor cells perform this by binding with either PD-L1 or PD-L2 or even other receptors to the T cells and tell them, don't attack me, I'm belonging to you. So the tumor cells can grow and the T cells do not attack them. But if we use antibodies against the receptor on the T cells, then PD-L1 and PD-L2 cannot bind, and the T cells are activated. The interaction is blocked, and this can lead to a very effective immune response in the tumors. So the detection of PD-L1, which silences the T cells, can be used as an alternative for patient stratification and therapy monitoring. We have published this in 2016, and we also have started to use this on tumor spheres, on the growing tumor cells. Here is an example. You see the upper row, the cell is positive for EpCAM, and it's also positive for PD-L1. It's not positive for CD45. In the lower row, there is again a cell which is positive for PD-L1 and positive for EpCAM, and the merge picture is on the right side. We have determined that PD-L1 positive circulating epithelial cells, they are more frequent than what is detected in the tumor, and they are higher frequency in PD-L1 positive cells in metastatic patients as compared to non-metastatic. And after radiation, indeed, the PD-L1 positive cells can also increase. Here again, one case where the patient had a metastatic malignant melanoma, stage 4, metastasis in the liver and the lung. It was diagnosed in March 2017. It was treated with surgery, no chemo, no radiotherapy, and already in December 2017, multiple liver metastases were detected. So the patient was treated with continuous therapy with nivolumab. He had a very good clinical response, regression of all metastases, and in contrast to the 100% positive circulating epithelial cells at the start, there was a continuous decrease, the dotted line, of PD-L1 positive cells during treatment, and not as stable, but also the circulating tumor cells were decreasing, but just recently we saw a re-increase, so this patient needs to be monitored further. But nivolumab led to a very good response and to a reduction in PD-L1 positive cells. This is another patient, a patient who had primary metastatic breast cancer. She had metastasis in the liver. Her tumor was estrogen receptor positive, progesterone receptor positive, and HER2 positive, and a high Ki67. She after chemotherapy was under targeted and hormone therapy, and there was no therapy with checkpoint inhibitors at that time. So she paid it herself. And after the first administration, the metastasis in the liver had become significantly smaller. Her PD-L1 positive cells decreased, and after a continuous increase in circulating cells, a renewed administration of IPI and NIVO was applied. And again, the cell numbers decreased and the percentage of PD-L1 positive cells also decreased. But in the months following immunotherapy, the cell count still remained low, but the proportion of PD-L1 cells again increased. This means that the small part of remaining cells were preferentially the PD-L1 positive cells. She has now repeatedly been treated again and again, and she is well, and she even got married recently. So this is how we can monitor the PD-L1 positive cells in the blood of the patients. So we are able to precisely characterize circulating epithelial cells in terms whether they have receptors relevant to the targeted therapies. And for example, we can observe a significant reduction in the percentage of PD-L1 positive circulating epithelial cells and HER2 positive circulating cells during an effective targeted therapy. When is it meaningful to do such analysis on the circulating cells? For example, if a biopsy to obtain information about the tumor characteristics is not possible, or if recurrence or progression occurs during the course of a targeted therapy. And in addition, sometimes if the origin of the tumor is unknown. So do you have questions about this?
Yes, we have some questions. One question, it's a three-part question. Did you ever have a patient which was in remission for a long time, and after performing main tract testing, there was still no detection of circulating tumor cells in the sample?
Yes, we do. We have some who have stopped endocrine treatment, who were low or zero, no cells detectable during endocrine treatment, and then even after endocrine treatment remained without any circulating tumor cells.
When could be said that a patient is in remission for sure?
Oh, I'm sorry. I think this is not possible during the course of a tumor disease, because we know that on one hand, cells can hide in different tissues, in niches, and still we don't know how these quiescent tumor cells can be activated. We know that in some cases, inflammation can activate resting or dormant tumor cells, possibly also during virus infections. Still, we do not know how long these cells can be dormant and how they can be reactivated.
Do you have any guidelines regarding tests that patients should follow during a remission or a therapy?
Well, initially, especially if therapy has been ended or endocrine therapy has been stopped, it would be helpful to do it first every 3 months and then extend it up to 1 year or even longer. And we have patients where we have seen the same cell numbers after several years, even up to 6 years. Dormant cells, so the presence of the cells is not indicative of metastasis, only an increase, and the cells can be dormant for extensively long times.
So far, that's all the questions. I think we can continue.
So What do we need and how often should the blood be drawn? Usually we require or request 2 times 7.5 ml EDTA blood samples. It's important that the blood samples should not be cool. They should be kept at room temperatures. When could we recommend sampling? Before a neoadjuvant chemotherapy, and then at the end of the neoadjuvant chemotherapy. If surgery has been performed, it should be waited about 3 to 6 weeks until blood can be drawn, because during surgery, cells can be mobilized and eliminated, so we would wait for this time. If there is a request for monitoring a chemotherapy, then it should be always 2 to 3 weeks after a chemotherapy cycle and 2 to 3 weeks after completion of therapy. During hormone and maintenance therapy, blood sampling is possible at any time. And if cell numbers remain stable, we recommend first every 3 months, and then, as I said, extended times. And blood sampling is also possible at any time during a therapy-free period. Are there any more questions?
There's one more question. Did you ever see a decrease in CTCs but still metastases were growing?
Yeah, unfortunately, that is possible. And we assume that in this case, the therapy was working in principle. And this was seen at the circulating cells, which respond and which decrease. But it's quite frequent for metastatic disease that the drugs given or the substances given do not enter the metastases or the tumors sufficiently to also block the growth of the cells in the metastases. And that's certainly the reason why many therapies directed against metastatic disease are not effective. That's seen without looking for the circulating cells, but the circulating cells tell us that in principle it's working. So the question is whether there can be an increase in concentration or whether the metastases can somehow be treated to make them more permeable to the respective substances.
Right, one more question. Does an increase in CTCs usually mean that there could be metastasis?
It tells us that the tumor is active. And this can be quite some time before metastases are detected. But our analysis of our recent 15 years results have told us that those with increasing cell numbers have a up to 8 to 11-fold higher probability to develop metastasis than those with decreasing cell numbers. So it's an indication that there's something going on and it should be monitored or treated.
Right, another question, now it's coming. In general, on which organs is the main tract more sensitive?
It is sensitive at cells seeded by epithelial tumors. And non-epithelial tumors, in part sarcomas, or those who have only part of the cells with epithelial antigen, we have difficulties to detect them. And it's not possible to monitor blood diseases because our approach is exactly the differentiation of the tumor cells from the blood cells.
The 8-11-fold increase probability to develop metastasis you mentioned, is
Yes.
that the same for all cancers?
We have analyzed it especially now for colon cancer and for breast cancer, and we are just at the moment determining it for prostate cancer. In principle, it's always an increasing cell number indicating tumor activity and a decreasing cell number or stable cell number that the cells that are present are dormant. In principle, it's for all cancers or for all tumors where we can determine cell numbers.
There are no questions anymore. I think that's it.
So that's the end. I thank you for your attention. And in addition to the questions asked here, you always can contact us at maintrack@laborbrachmann.de.